next 90 minutes together, we are going to solve America's health disparity issue. Well, I tell you what, next 79 minutes, we are going to because we have with us here a think tank of experts who are helping guide us through some of these issues and provide some responses. We have some of the finest minds and some of the biggest heavy hitters in healthcare in Kansas City with us today. On the left, to your far left as you see her there, is Dr. Betty Dree. She's the Dean of the School of Medicine at the University of Missouri, Kansas City. Next to her, you'll see Dr. Alan Greiner. He's the Associate Professor of Family Medicine. Guards. Okay. Dr. Alan Greiner is the Associate Professor of Family Medicine, Preventive Medicine, and Public Health at the University of Kansas Medical Center. He's also a practicing family physician. Next to him, of course, is Mr. Rich Hastings, the man in charge, the CEO of St. Luke's Health System. Laura Lacey Horn is next to Rich, and she is the Dean of the School of Nursing at the University of Missouri, Kansas City. Also with us, Kevin Hicks, the President and Chief Executive Officer at Research Medical Center, which is part of the HCA Health System. He was the CEO of the Overland Park Regional Medical Center before that. Joyce Portela is the Executive Vice President and Chief Operating Officer at Shawnee Mission Medical Center. And Sandra Wilsey is Executive Vice President for Academic Affairs and Provost and Dean at the College of Osteopathic Medicine at the Kansas City University of Medicine and Biosciences. She has the largest business card of anyone here on our panel today. This is your agenda, ladies and gentlemen. We asked you to submit questions. We asked you to submit questions to the conference. This is not the agenda of our panelists. This is not the agenda of Nick Haynes or KCPT Public Television, but the questions you wanted to know about. And we're going to go through those and roll up our sleeves immediately. An undocumented worker arrives, Joyce, at Shawnee Mission Medical Center. He arrives at Shawnee Mission Medical Center. He has no health care benefits. He doesn't speak English. Do you treat him at Shawnee Mission Medical Center, Joyce?
Absolutely.
Do you have translation services available for him at Shawnee Mission Medical Center?
24/7.
Is that true for our other heads of hospitals here, Kevin Hicks at Research?
Yes, that's correct.
Was that true at Overland Park Regional Medical
Yes.
Center? You don't turn anyone away who doesn't have health benefits?
That's correct.
Rich Hastings, is that the experience at St. Luke's?
It is. Because we're affiliated with Truman through our teaching program, we also accept a lot of folks in that same situation who are transferred from Truman to St. Luke's because of our high-end services.
Alan, how about at KU Medical Center?
I'm certainly not here representing KU Medical Center or the hospital per se. My faculty position is actually on the university side, but I think that certainly EMTALA laws and other sorts of legal regulations require service. I think for outpatient care or non-emergent services, there might be other issues. There is movement in the city to develop specialty care programs for uninsured and undocumented individuals, both on the Kansas and Missouri side. The YJOCO Care program is new on Kansas, and I think there's a Metro Med-sponsored program on the Missouri side, which are useful for people who they're not emergent enough to go to an emergency room and then get in for care, but they might need surgery or some other service that has to be arranged as an outpatient. But it's still a problem.
The Kansas City Chronic Disease Coalition reports that on average, people of color have a life expectancy 11 years less than whites, just one of the many statistics that show this glaring gap between the health outcomes of Latinos and African Americans in this community compared to whites in this metro. Rich Hastings, what is your hospital doing about that?
Well, let's start with, I think most of you are aware that St. Luke's runs Cabot Clinic, Cabot Clinic is a Hispanic directed clinic on the west side. It was losing money and about to go broke, and it was in a very old building. And we took it over. They're in a brand new space. It's a space equal to any office building that we have in the St. Luke system. So we have been working in the community. We have a partnership with Swope Parkway, and that works even in our emergency room. And so we're able to get to solve the issue that Alan talked about, and that is if truly emergent care is not required, but just medical care by some specialty, we can actually do that inside St. Luke's and also have a referral line for them to go to Swope or to our clinics. We run clinics, outpatient clinics, in virtually all disciplines at St. Luke's for people who do not have the ability to pay, or they might be, if they have some ability to pay, it's a partial pay. I think KU does as well in that area.
Joyce Patella at Shawnee Mission Medical Center, the same issue. We have these glaring gaps between the outcomes of Latinos and African Americans in this community compared to whites. What is Shawnee Mission Medical Center doing about that, if anything?
Well, I can think of two things right off the top of my head. One that we're doing is something Shawnee Mission has done for a number of years, as has every hospital in Johnson County. We all participate in the Health Partnership Clinic of Johnson County, both with donations as well as participation on the operating board. And this clinic is set up to see those who have no other health care option. It is essentially a free clinic, although some pay up to $5 a visit. But it sees the vast majority of the patients seen in this clinic are minority populations. And the purpose of the clinic is to help people not sink into irreversible conditions with particularly diabetes, as well as conditions that can lead to stroke. Another thing we've done very recently is worked with the NAACP to address the African American community in our high schools and invite those students into Shawnee Mission to help them understand what health care can do for them in careers, as well as it's no secret that in the African American community, for some very long-standing reasons, there are those who are afraid of health care. And so we seek to address that issue with the students while they're young, before they can develop those fears and be able to access health care that will keep them healthier and address that disparity.
Kevin.
Well, first of all, I think we need to say that the healthcare community, the healthcare providers as a community, can't do enough fast enough to close the gap on that percentage you just described. But a couple of examples at Research Medical Center, if you were to drill down in your statistic and start looking at disease categories, you would probably find a couple areas that are profound in terms of cancer and diabetes. An example would be in cooperation with Dr. John Sheldon, who heads up our private practice radiation therapy group. This fall, we hope and are planning on establishing a specific symposium on the disparities in cancer care, cancer outcomes, specifically for African Americans. And because the research is very clear about the disparity there. And so this fall, in cooperation with a couple of organizations, we will be presenting such a symposium, which will bring people like this together and further study this initiative. Another big area would be diabetes. I'm sure is another area that is a contributor to that statistic that you named. Research Medical Center has long been active with a complete diabetes program. We do this in conjunction with our foundation, the Research Medical Center Foundation, for the provision of both outpatient and inpatient care. I would say, just thinking kind of off the top of my head, the third area has to do with access. As Joyce said, we need to create opportunities for minorities to be able to access the care, and oftentimes, and that needs to be a physician. So we have a very focused physician recruitment program that matches the diversity of our service area, of the population of our service area. So we're proud of the fact that we have a very diverse medical staff, particularly as you look at the last 5 years in the mix of new physicians, mostly primary care physicians that we've added that are from the minority classes.
I have to say there's a lot of questions we have that are relating to our academic institutions. We're going to go to those. But you mentioned, Kevin, that this is a tough nut to crack. We're never going to be able to keep up with all of these people and all of the problems that we have. Can any of you point to any pocket of excellence, a pocket of success in Kansas City where we are seeing at least one organization, one facility, one group that is somehow doing an exemplary job of narrowing that healthcare disparity between Latinos and whites or African Americans and whites? Is there any one of those sites that we see in Kansas City? Rich Hastings.
Well, I think Cabot Clinic, and I'm more than happy to have anybody come down and take a look at Cabot Clinic, because that's precisely what we are doing there, and have been doing for 99 years or pretty close to that.
If it's working, then why isn't everybody doing that?
Well, it's expensive, and I didn't think about this as a question, but if I looked at the number of paying customers, probably at least a third pay nothing. And the rest of the others, we're able to get them on Medicaid, unless they're a Kansas resident. And if they're a Kansas resident, we might get them on Medicaid, but Medicaid pays so little in Kansas that it's not very worth going through all the paperwork. But I think certainly in the area of obstetrics, and you're talking the film that you showed, and neonatal care, roughly half of the Hispanic population is treated at St. Luke's Hospital, or delivered at St. Luke's Hospital in terms of obstetrics. And they therefore also have our neonatal coverage, which is unique in that fact that we have neonatologists and perinatologists in-house 24/7. So for this particular population, virtually they receive the same level of care as the white population. Where we suffer, and again, Cabot does this, but is the continuing care that is necessary following dismissal from the hospital. And that's one of the programs that I'm especially proud of at Cabot, because they do provide follow-up care. So there are areas where we're not doing as much as we should, but each institution, if you just take St. Luke's Hospital alone, we gave away about $60 million worth, based on cost, $60 million worth of free care last year. If you think about that, there's only so much that any one group of institutions can do, and I think most of the hospitals in Kansas City, as is evidenced by recent reports, are providing their fair share.
You say there's only so much one institution can do. Do you ever get together with your peers at these other hospitals? Do you, Rich Hastings, get together with the head of HCA Midwest or the head of the KU Hospital or any of the head of Shawnee Mission Medical Center and say, we can't do this alone. We know we have these disparities in healthcare. We know we have all of these people without health insurance. Can we collectively come together and do something with it beyond just our hospital? Does that ever happen?
It used to happen all the time. I look at Wynn Preston over here. We used to do it all the time. But the government has made it, if two of us show up together, if I sit down with the president of HCA, people are going to think we're talking about conspiring to do something wrong. So we basically don't talk to each other very much anymore. That's just the way it is. How we try to relate to that is to work with community programs like I can't think of Sam's last name right now, but Sam Rogers.
Yes.
We work with Cabot Clinic, obviously. We work with SWOPE and try to work through them, filling a niche, and then they really become the arbiters of what happens out there, because they can talk to each of us and be okay. But if I were to call up Kevin and say, Kevin, you know, we got a problem between your place and our place, we need to get together and figure out how to settle or serve there, I don't know how long it would be, but somebody would sue us, and the government would come and give us a jumpsuit.
So you never meet with your colleagues from these other hospitals?
Only in highly organized meetings where there are attorneys.
Sandra.
Importantly, I think you've been talking about acute care, but I'd like to talk about preventive care. And everyone agrees, thank you, everyone agrees that the children are our future. And I would like to just tell the group about a program that Kansas City University of Medicine and Biosciences has, which really works with children. For many years, we've had a program called Score One for Health, and I see a few heads nodding, and some of you know about that. Our students and our faculty, and we partner with UMKC School of Nursing and with the dental school to go into the inner city schools and screen over 13,000 children annually for health problems, vision, dental, things that are going to lead to long-term chronic disease. And we're very proud of that. We've recently, just this year, received a grant to go into some of the Kansas inner city underserved schools. And I think we can't focus enough on preventive services for underserved populations. So I'll just list that as something that we've been doing that we're very proud of.
I hate to keep going on the same territory, but Mr. Hastings, when President Bush wanted to do something in relation to health care and unveil a new plan, he went to a St. Luke's institution, did he not? If the government is the problem in terms of collaborating with your fellow hospital CEOs, couldn't a quick word to the president himself solve that problem for you?
Believe it or not, I did talk to the president about it. We've had the opportunity to have the president on several occasions. And I can say that some things have changed to allow us to have it better than it was. For example, I now can do things working with my physicians that I couldn't do a year ago, because then it was called annulment, and now the new Stark regulations has given us some more freedom. If the IRS would lessen their requirements, then it'd make it a little easier. But yes, we talk to the president on a regular basis. He chose St. Luke's Lee Summit because it's all digital, and that is one of the president's major initiatives in healthcare, is to get everything digital, so that if you show up in a hospital in Texas, that your medical records and all of what has happened to you medically can be immediately transferred immediately, so that care in the future would be will be much better because of that capability.
We've had short thrift thus far to our academic institutions, and yet a lot of the questions relate to them. And so Betty Dries, get ready with a microphone if you could, over at the School of Medicine at UMKC. Currently, what is and how much is being taught in our medical schools to teach cultural competency and sensitivity to new doctors?
It's actually quite a lot that's being done, partly because I think there's a general recognition that it's the right thing to do, and also because it's become an accreditation standard for the MD granting medical schools. And this standard for accreditation just went into effect within the last few years, and we're still figuring out how you demonstrate that you're training people in cultural competency. What we have done is we have 9 competencies for our students that they are expected to get by the time they graduate. It includes things such as clinical skills, etc. But cultural competency is one of the competencies that we expect our students to gain.
Can you put a little bit of flesh on the bones? We use the word cultural competency. Can you just name me something that a new doctor is now going to have to know when they go to the School of Medicine at the UMKC that they didn't say a decade ago even?
They need to understand the patient's perspective toward illness and how their own cultural values and their background impacts on their experience of illness and health, both.
How about at the KU Medical Center, Alan?
There's been a lot of extensive change there recently, too. We have a brand new curriculum that just started this fall. Actually, our Associate Director for Cultural Diversity is here. Our Office of Cultural Enhancement and Diversity is here, and she's actually, in that new curriculum, putting in 16 new components related to cultural competency, so that the students, in theory, will be able to work with patients of a variety of cultures at a much earlier rate. We also have a standardized patient program, which I know they have at UMKC as well, where you have actors coming in, working with students from the very first months of medical school. And those actors and actresses are a diverse set that come with a scripted set of problems that a lot of times we can model different cultural and illness issues that can then sensitize the students. It's still a problem, and I think we need to follow through with more things as students get further along. We have some training programs as well that I think help students along those lines too. We have programs that put students out in the community fairly extensively, so they're working in different sectors of the city and also in Kansas across the state, so they get exposed to different communities. I think that's helpful as well.
It's not only doctors, of course, Laura, at the School of Nursing at UMKC that are exposed to patients. It's predominantly nurses.
That's right.
Are they getting this as well?
They certainly are. In fact, as Betty said, it's part of accreditation standards for nursing education. It's been in our accreditation standards for quite a many years, and probably 10 or 15 years that I can recall, knowing that that standard is there. So we have integrated throughout our curriculum for both the undergraduate and the master's program activities and clinical experiences and content that help them to learn and develop cultural awareness and cultural competencies.
Can you name me one thing that someone going to the nursing school at UMKC is now forced to do, required to do, that they weren't, say, 5-10 years ago?
Okay, that's a good question. One of the things that we do at UMKC that I would say we forced it 5 years ago, but maybe not many more than that, is we require all of our students to spend some time in the clinical settings, in the community settings, working with diverse populations. Whether it's at Operation Breakthrough, working with the African American population primarily from that inner city area. We've done a lot out at Richard Cabot Clinic. So the students are out there, and that is part of their requirement. We track whether or not they have been in some of these settings for the underserved.
Sandra, you have been nodding your head in agreement to things you've heard.
Yes, thank you. We actually built a Center for Clinical Competence, and a very important piece of that is cultural competence. And I want to remind people that cultural competence goes beyond race, but also includes gender, any protected population, HIV patients, gender preference, all sorts of things. So we, first and foremost, have always worked very hard with our students to listen. And that's so key. But they now they take a very careful and organized approach to obtaining the cultural history of patients. And understanding, for example, Ramadan. There will be patients during Ramadan that will not take medications during the day. Unless you're aware of that aspect of the patient's history, you're not going to give them the best possible care and work with them to make sure that their medical treatment plan fits their culture.
But these are going to be all of the new nurses and the new doctors. My doctor is an insensitive jerk. Now, come on, Joyce, at Shawnee Mission Medical Center. What about the doctors you already have there? Are they forced, are they required to maintain their privileges at your hospital? To have cultural competency and sensitivity classes to stay there?
The independent physicians are not currently required, although those opportunities are certainly available to every one of them. I will say that every employed physician at Shawnee Mission is required to attend cultural diversity, sensitivity classes that involve everything from cultural diversities also to spiritual diversities. And the varying expectations that patients have when they come into our hospital, all employees are also required to attend a class on an annual basis and to demonstrate competence in this area every single year.
Kevin, what about at HCA hospitals? Does a doctor have to do anything once they've gone through medical school?
Similar to Joyce, we have a mix of employed physicians and those that are in private practice that work at our hospitals and at Research Medical Center. A growing number of them at Research are employed physicians. And as employed as a part of the HCA system, they're required to take diversity training programs like all of our employees are on an annual basis. So through that, they receive that. We have at Research Medical Center a very active family practice residency program, and embedded in that residency program, as part of the accrediting body for physician residencies, they are required to take X number of diversity training programs per cycle, per 18-month cycle. I'd say lastly, again, back from the hospital's perspective, we have a very robust committee of our medical staff that monitors physician behavior that may be outside of their clinical practice. It may not be so specific to their clinical practice, and it monitors a wide range of activities that may need to be addressed. And I could, if we were in a more private setting, I could talk to you about 2 or 3 such incidences that have arose over the last few months
Mr. Hicks,
that this committee has addressed.
This is like Las Vegas. Everything that's said in this room stays in this room.
Well, I'll refer to Rich's comment earlier about the lawyers and peer review and privileged information. So, yeah.
Mr. Hastings, the same comment to you about your doctors, the ones who have already gone through medical school. Is there any requirement on them?
Well, first of all, we're an academic medical center associated with the university, and so we're actually training the docs, and so they're very much involved in it from the very beginning. Plus, we have a program that's led by Dr. Weaver, who is a graduate of UMKC, an African American who's responsible for our medical staff diversity. There's a program out now, and I know that everybody is in some degree of implementation. It's called the CLASS program. It's a culturally sensitive program that's a national program, and I think Dr. Weaver may be there today, but in any event, in training. So yes, it's constant. And because we're an academic medical center, education is going on all the time. You asked a question of Kevin. We also have a nursing college, and so we have the same requirements. So virtually our nursing and our physicians are constantly involved in diversity. And I just wanted to tell one incident because I think this kind of gives it. Nurses really are the first line of health care in a hospital. Physicians are very important, but nurses are more important from my perspective. And I'll give you an example. We had a Buddhist who was visiting here in Kansas City. He was brought to our hospital. He was actually dead on arrival. And there are some requirements. And one of our nurses, because we have these little cards for every kind of culture and religious activity, so that we can know what we're supposed to do given that kind of circumstance. Well, in this particular sect of Buddhism that the gentleman was in, you're required not to let the body out of the hospital by them, by the religion, because the soul can take up to 3 days to leave the body. It's against the law in Missouri to keep a dead patient in a regular hospital room for 3 days, but we did. And it was because one nurse was very sensitive, and if you come to my office, you'll see sitting a letter from the Dalai Lama, who wrote us a letter giving us appreciation. That came from the nurses. It's because of the training that they receive as part of their normal ongoing training.
Let's dig a little even further here, because most of us, if you're a patient, it's the first line of defense is not the doctor or the nurse, it's the person at the reception desk, the other people, the vast majority of the folks who work at the hospital. If you don't have insurance, if you're looking a little shabby, where's the sensitivity training for those other people who work at your hospitals? Is there any choice at Shawnee Mission Medical Center?
Absolutely. Our diversity and cultural sensitivity class addresses those who may be different from you in any way.
And this is for all of your staff at Shawnee Mission Medical Center?
Yes, it is. And those differences, as I said before, can be in ethnicity and race. It can be in their spiritual or faith tradition. It can be in what they're wearing. It can be just plain in what they look like. And how we approach diversity is that people are different one from another, and you need to be sensitive about those differences regardless of what they are or what the background of that person is. It would be my expectation that a homeless person who came in with no shoes and overalls and was filthy dirty and had matted hair would be treated with the same dignity and respect as someone who came in looking like the rest of us who are sitting here.
Kevin? We know about the doctors that are getting the sensitivity training and the nurses. What about your reception staff and anybody else who comes in contact with the patient?
Answer would be similar to Joyce's. Our program within HCA, all HCA hospitals, is hospital-wide. Again, on an annual basis, we ensure, both at orientation for new employees and on at least an annual basis, we have a very specific program that includes role-playing, describing the very kinds of incidences that you just described, and general updates, and that all of our employees go through, again, on at least an annual basis. The comment I think the physician from KU mentioned as well, in addition to that, the federal regulations, if you will, have been so embedded in what hospitals do that we naturally know to take care of all patients. And it's just what we do. The real discussion comes with once the patient is beyond their immediate needs for the hospitalization, the follow-up care, where they go from there, that's where the problems become greater. But people of all walks of life can walk in any one of our hospitals today and will receive care, I'd say, equal to any of their peers.
And what our panelists don't know, ladies and gentlemen, at this media time, we have KCPT cameras going into each of those hospitals with hidden cameras, and we'll be beaming the results a little later on, just to hold the feet to the fire. Okay, Rich Hastings, we short-circuited you, but on the rest of the staff, do they get training?
I think it's pretty well. It's the same for everybody.
Let's bring our academic folks back in here, because one of the questions here is, how does your medical school screening committee, we'll begin with you, Alan. Yeah, you couldn't pass the microphone off. How does your medical school screening committee reflect the ethnic and racial background of the community they serve here in Kansas City?
I just stepped off our admissions committee this year, so I should know. Actually, not very well, to tell you the truth. I don't want to paint an overly rosy picture of all the stuff we do. It's a problem. We do, I think, have some success in taking non-traditional students, so students who've had other careers, students who may not have perfect medical admissions college test scores, and that's actually reflected in some recent research. Our medical school graduates the highest percentage of students who go into family medicine of any medical school in the country, and that's a 3-year running average. And family physicians, I mean, I'm very biased, you can imagine, but family physicians are the only specialty in medicine that distributes geographically the same way the population distributes geographically, whether that's an urban underserved setting or a rural underserved setting. So a plug for family medicine and a plug for our schools, we do that. Now, we aren't that diverse on the admissions committee. We could do better. We get, if we get 25 to 30% of our graduates into family medicine, that's great, but that's not enough. I don't think that does what we need to do for the community. The community needs more primary care. So
I want to hear from the others, but why do you think that is, very briefly, Alan? Why is that you're not getting the numbers you want?
I think the financial incentives in healthcare are perverse. There's nothing to incent people to go into primary care. It's hard for me to tell a medical student, go into primary care and do what I do, even though you're likely to make 3 to 4 times more doing another specialty than what I make. It's a self-esteem issue. I'm not going to tell some student, do something that all of society tells you not to do. We have an issue with finances and money in this country, and that's kind of at the root of a lot of the healthcare issues we're talking about.
Betty Dries at UMKC, how is your medical school screening committee reflecting the ethnic and racial diversity of the community that you are serving?
We would consider that we serve the entire state of Missouri, not just the city of Kansas City, and the underrepresented minorities in Missouri is about 13% now. Out of our admissions committee of about 19, we have 2 people who are underrepresented minorities, so it's fairly close percentage-wise. The rest of the other composition of the selection committee is made up to include students, to include community members, to include representatives from each of our hospitals. There's good gender diversity on it. So it's something that we pay a lot of attention to in our admissions process. Can we do better? Of course we can do better. We're not where we want to be.
What stops you doing better?
The thing that is the biggest challenge for us in terms of recruiting more underrepresented minorities is the applicant pool. Getting enough underrepresented minorities to apply. We had more success this year. We have yet to know how many will accept our offers. The other thing that is a huge issue in terms of recruitment of underrepresented minorities is the financial situation. The cost of going to medical school has continued to accelerate. The average debt for medical schools, for medical students, is $100,000 leaving medical school. It's a huge issue in recruiting underrepresented minorities, rural students, people who want to go into primary care.
Sandra?
I would echo that all of us could do better. We certainly have reached out to our community and have engaged people such as from the Don Bosco Center, from Newhouse, battered shelters, to help participate and interview our students. In addition, we recently put into place a program where when we have minority students coming in to interview at our school, and we actually have students from about 40 different states that come to our school and foreign countries, we actually have a partnership program where those minority students actually entertain, keep in their home, and give the tours to those other minority students, because we didn't feel, I think we're challenged as many of the other schools are in having as large a minority population of students as we'd like. So we have really partnered out and reached out to the community in that way. But I would echo, I think we can all do better. And we love to have minority students. We know that the population of the United States has changed. We are a global community, and we need to be training medical students that will mirror the communities that they serve. So it's extremely important to us, but as Dr. Dries said, if they're going, we may accept them, but they may get 5 other schools to give them 100% scholarships, and you can't blame the students then for taking those opportunities. So it's a challenge. I
want to get to Laura in just a second. So we've identified what the problem is. Can anybody hint at a solution?
I think having, the ability to provide more scholarships, full scholarships for these students, outreach. We are outreaching with the Score One for Health, other programs in the schools. Our students are volunteering, trying to get the word out that they should strive for the highest career that they can get and that sort of thing. Starts at the grassroots level.
Yeah, I think there are successful programs around the country in terms of pipeline, in terms of hooking up with grade school, high school students, mentoring them along, supporting them before admission. There's also the model, I mentioned this in a breakout this morning. I was a co-author on a paper that we published a couple months ago that says you actually can change admissions to select for factors of diversity and interest in serving the underserved ahead of grades and GPAs in college and MCAT scores. That's actually never been tested, because there's no medical school in this country that necessarily wants to worry about supporting students they think will have academic difficulty. Now I think it could be done. It could be tested. Maybe some of us, the schools in Kansas City, could try it. But you could actually put diversity ahead of GPA, say, as a selection factor for medical school admissions or nursing school admissions or whatever it was, and then you might need more support within your school so that you didn't have academic difficulty with those students. But I think those sorts of things need to be tried too.
At the School of Nursing at UMKC, Laura Lacey Horn, is it still an issue then in nursing the same way as it is?
It is an issue in nursing. If you just look at the nursing profession in general, there is a great shortage of not just nurses, but nurses representing ethnic minority groups. So at the School of Nursing, we're quite different, I think, in some of our issues than the medical schools are, in that there are 17 schools of nursing in our Kansas City region alone, and that we are recruiting, majority of our students do come from our area. Not all of them, but the majority do. So we've made a real commitment for recruitment and retention of students coming from the urban core or students coming from ethnic minority populations. And so we have a pipeline program like Sandra was talking about, where we work with the high school students in helping them prepare for what college will be like in college life socially as well as academically, and put them through a year-long program, and they can stay in it as many years in high school as they choose. They can come in as freshmen and stay 4 years, and we build on their experiences. And then hopefully they at least apply somewhere to college, whether it's nursing or not. We've helped prepare them for college.
Sandra.
If I could just add one thing, something that I neglected to mention, I wouldn't be doing justice to our school. We actually have partnered with the state of Alabama and the black belt colleges there that are traditionally minority to have a pipeline directly to our school and then to return them back to their state for postgraduate training. And we are just starting to realize, we have 5 students this year that will return back, and we hope to make that we're trying to make that as large a focus as we can. Certainly we feel a responsibility to this general area, but we are a private school and we do take students from a number of states. So just wanted to add that.
Laura.
Yes, if I can add something else too. One of the challenges we have beyond undergraduate education is increasing the minority population of nurses in our master's and doctoral programs. And that's because the pool actually is very small, so we've had to look at how can we reach out beyond just the Kansas City area because of the small population of minority nurses in our area, and encourage others to come in for graduate studies and doctoral education. So our doctoral program, for example, 2 faculty have spent the last year and a half going to a lot of the primarily black colleges and Hispanic serving institutions that have nursing programs to encourage their students that want to go on for doctoral education. And we've made it so that they can do it through long distance, through online, and some limited time in Kansas City. So we've also tried to look at how do we deal with those issues at the advanced levels of nursing education as well.
Just a moment, ladies and gentlemen. We're going to engage you. If you've been sitting there with your hands under here thinking, I'm desperate to say something to these folks, you can have an opportunity in a moment. But we want pithy, insightful questions, not 6 or 7 minute long comments. But I have a specific question which was brought up, and it gets back to the heart of some of these disparities. And we'll leave this open for you to answer. Studies like the Kaiser Daily Health Policy Report show that minority women in our area, particularly Latinos, are far less likely to receive prenatal care in the first trimester of their pregnancies than whites. What is your hospital doing to promote the importance of early prenatal care to Hispanic women? Joyce at Shawnee Mission Medical Center.
Well, Shawnee Mission is well known to deliver more babies than any other hospital in the Kansas City area. We have a very active women's and children's program, and we actually have some nurses who are specially trained to deal with the Hispanic population and the special needs that they may have in terms of information and education, certainly communication issues. And we've been very active through our Speaking of Women's Health initiative and many other activities in the community to reach out to the Hispanic community and make sure that they know what is available to them. We've worked with our physicians who are on staff to make sure that they also have accessibility in their offices. I will say that, again, as you said, I don't want to paint too rosy a picture. It's frustrating because sometimes we don't know who they are until after it's that first trimester, and that's very frustrating to not be making more progress than we are. But we believe that we have made much progress because the number of folks we're seeing earlier in their pregnancies is increasing.
Rich Hastings at St. Luke's Health System.
I think this sounds like a Cabot advertisement, but that's what we do. That's all part of our program at Cabot, and so we reach a large number. And it kind of goes to a question you asked earlier. We have adopted the West Side as a place that we can focus on, and in the Hispanic or Latin community, and then in the African American. We work through the churches because that's the easiest place to work. And so, yes, we're very much involved in that. We consider that actually with pride what we do in the area, especially at Cabot Clinic.
If one of the other hospital chains came to you and said, hey, we'd love to replicate the experience that you've had there at Cabot, hey, help us, tell us how you did that. Would you be sharing that information,
Sure.
Mr. Hastings?
Sure. We would share everything except our price list. No, sorry, that's inside for anybody who knows the legal system. But yes, we would share.
Okay, Kevin, I'm not asking you to share. I'm just asking you what are you doing for those prenatal Hispanic women who are coming to your hospital and are not getting the same kinds of prenatal care as the white population is?
Well, I'll answer the question with in the broader context of the minority females accessing care. We have, again, I'll say, I think that we today obviously fall well short of meeting those needs. We see that by the situations that we run into in terms of late-term pregnancies coming to our hospital that we're delivering babies without adequate prenatal care. Having said that, we had a practitioner, an OB-GYN physician, and she has been dedicated to treating this population. And she was at one time in private practice, had decided that she, for no surprise, could not make a living, couldn't feed her family doing that work, and was getting ready to relocate. And we opted to employ her, to stabilize her and recruit a partner or a mid-level provider into her practice to further the access for these folks. So a lot of what we probably need to do more of is financially strengthening the access points, which are the physicians and the primary care providers that are in the front line of the community.
This was never on the agenda, Mr. Hicks, and we're going to take some questions from our audience, but you did come, for a long time you were at the Overland Park Regional Medical Center, now at Research Medical Center, both under the same management umbrella. But what was the big difference for you in terms of the wake-up call there and the differences that you were seeing in terms of health care and the needs that were there from moving from Johnson County onto the other side of the state line at Research?
I don't think you have enough time in your program here. The question, yeah, the differences between the two. Well, it's obviously very distinct populations that we're serving. The work is much the same. As you said, I work for the same company, HCA. Hospital services are very, very similar between Overland Park Regional and Research Medical Center, including things like a trauma and a level 3 neonatal intensive care unit, which are the kinds of services that get access by these patients who don't have money, underinsured, uninsured. So, you know, much of it was the same. It has been the same. Just the population is different, but how we go about trying to provide services really doesn't change.
We are all stakeholders, ladies and gentlemen, in this conversation. If you have a question for our think tank of experts, we're going right up to the front. It'll take you just a moment in those boots there, Gwen. Right up the front here.
Secretary Granby challenged us to address prevention, emphasizing tobacco elimination, increased physical activity, and improved nutrition.
You need to repeat that.
What I said was Secretary Granby challenged us all here during lunch to address prevention, the emphasis on tobacco elimination, improved nutrition, and increased physical activity. Nick, I see you as the moderator and would ask if you would become a moderator for this group to be a think tank to address the issue and come up with a plan over the next year to improve prevention at the community level around those three areas. Would you take on that challenge?
I will just to rework Rich Hastings' quip. I haven't seen the price list. Would I do that? Of course I would.
Could I ask the panelists to consider that also? To be a think tank to really come up with a plan jointly to make a difference.
I mean, there's a lot of potential solutions. I think that, you know, the issue really, again, is the perverse finances we're dealing with in healthcare. You know, nobody gets paid to do preventive care, even in the public health sector. You know, Secretary Granby mentioned I've actually worked with the checkup company a little bit in research that he's working with. They're doing that for free, which is great, but that's because nobody's going to pay for anything in prevention. I would like to see primary care expanded, as I mentioned. That's my bias. I think that would help if everybody had a medical home and a primary care provider, whether it's a nurse practitioner or physician or physician's assistant, that they trusted and had continuity with. I think that would facilitate prevention. but there's no fiscal incentive really for expanding those networks of primary care like there were in the 90s with managed care. There's other possibilities too. I mean, a lot of the people up here have been involved with safety net clinics and other entities that use KC CareLink here in the Metro system, which is an electronic registry system. I think I lobbied at one point a couple years ago that we should have preventive measures embedded in KC CareLink as a way for tracking and promoting that sort of work. But we should write grants, you know. Let's get together and write grants and try to get some money to do these things.
Just briefly, though, with a show of hands, are people willing to engage in future conversation to do this? Yes, Sandra? Yes, yes. Thank you very much. Dean Anderson is here from the University of Missouri Columbia Student Health Center with a question.
All right. Basically, I was kind of curious if you could speak to the issue of, I know that lesbians, gays, and bisexuals and transgendered folks have some of the highest health disparities that are out there. And I was wondering if any of your institutions do any kind of educational outreach to those communities, and what your policies are according to like visitation rights for same-sex partners.
Don't rush to answer the question, ladies and gentlemen.
Well, that's a big
question.
Thank
you, Mr.
That's
Hastings.
a big question, but I'll start just with the concept of I had never even heard of not allowing same-sex people being together in a hospital. I mean, that's not been an issue for us. I've only been at St. Luke's 31 years, so it could have been before I got there it was that way. So we have a non-discrimination policy. I think the bigger issue, the question that you have, is, and it comes through our health program, kind of answers your question too. All of our employees are, first of all, you pay less for your health insurance if you don't smoke. Two, if you take a health screening and do a health screen, we cut your insurance even more. And so that's for all types of issues. And three, if we find that you have something, then we will provide the program free or at a nominal charge in order to provide medical care. So we are involved in prevention. The area that we're working on that's the hardest nut to crack is the overweight issue. It probably is the most sensitive one that we're dealing with right now.
Back to Mr. Anderson's question. He was talking, though, also about, and I'm going to hear from the panel here, anyone doing outreach, just the same way you work with the Latino community or African Americans or any group you believe has issues in terms of healthcare disparities. Anybody actively having an outreach project designed to look at the areas of the gay, lesbian, transgender population?
I would say that we are working towards including that in our cultural competency education for our students, but furthermore, our clinical research center is conducting a number of studies which are specifically related to the communities that you're talking about, and those are the particular patients that we're recruiting for, because we recognize that there are healthcare disparities, and only really through clinical research projects that address that particular community will you be able to really make an impact on their care.
Anybody else want to respond to that?
As you know, on our campus, probably on your campus as well, there's a student group for that population. But what we have found, because a lot like what Sandra was saying, we're probably not real prepared to do that in terms of outreach. But what we have done, and in fact we did it just this fall and this winter, was had the safe training for our faculty and staff. And then those that participated put up in their windows, their office windows, and it indicates that they're a safe space for those students to come to should they have questions or just need some advice or some sort of support. So we're trying to reach out at that level, working with our students.
You know, unlike the United Kingdom where I come from, the American healthcare system has been, by and large, framed, a lot of them are religiously based, a religious affiliation, weakened over time. Is it for any of you with, for instance, Joyce, Seventh-day Adventist, isn't it? Is there any reason why you would not do any outreach with the gay, lesbian, and transgender community with their healthcare disparities?
I don't think that there's been a history of Adventist health system anywhere in the country doing specific outreach. I will say that it is my expectation, again, that this population be treated with the dignity and respect that every human being should be afforded. Additionally, you address the issue of visitation. I would be horrified if anyone in any of our hospitals were to treat a same-gender significant other or spouse or whatever they called each other in any way different than family. The other thing that I have personally encouraged many gay and lesbian couples over the years to do is address their wishes in advance directives for health care. To not have your wishes and who you want making medical decisions for you spelled out in writing is simply a travesty, and you're likely to run into troubles no matter who you are, no matter your sexual orientation, if you don't have your wishes spelled out. So let me do a commercial for that here very quickly. Be sure that you have your wishes spelled out in writing.
Thank you. Nancy Bauer is with the Missouri Nurses Association.
I'm glad to have this opportunity to ask this question and also to make a comment. Laura, I know that you have had some vision related to the workforce for the state of Missouri as it relates to nursing, and I know that you've done some really clear thinking on the issue of attraction of various kinds of ethnicities to nursing for the future. And you have several plans in that regard. Would you mind speaking to that, or is it too preliminary?
No, I can tell you just where we are with that. One of the things that we're talking about, I'm sure you all know there's a significant nursing shortage in our country. There's a significant shortage in our state and also in the Kansas City region. And so one of the things that working with MONA, the Missouri Nurses Association, and the two deans at the other two University of Missouri Schools of Nursing and some other people throughout the state, we're looking at developing a statewide initiative that would look at how do we support the educational programs to produce the numbers of students that need to be produced, how do we support the healthcare environment so that they are the kinds of environments that are supportive and so the retention rate's higher. And along with that, though, the part that's embedded in that Nancy's asking is, it's not just the numbers of students that we're interested in, but it's the ethnic makeup of those students, it's the race of those students, it's whether they're rural or whether they're from the inner city, and also the level of nursing education that's appropriate for that particular area. So we are going forward and hopefully have some legislation to take forward through MONA about advancing nursing workforce development in our state.
I'm at the front table now with Alan Tickwart, who is with the Healthcare Foundation of Greater Kansas City.
Yeah, there's a group of people that aren't really poor, and yet they don't have insurance. And I saw in my own life, on the beginning of my married life, and just recently, where I had a shoulder problem for 40 years and cost $32,000. Yet, thanks to Blue Cross, which I pay a heck of a lot for, high deductible when I'm an individual, it went down to about $13,000. Now, if I was that same person, and I'm not poor enough to get free service, but I got to pay for it, I'm going to get stuck with a $32,000. Now, how is that fair? And what do you do for a person like that? Because when I was with the Kansas Health Partners, people that went bankrupt was medical things about $25,000, $30,000. And that caused about 80% of the bankruptcies.
So, Kevin Hicks, at Research Medical Center, what are you doing for that patient who comes into your door? Are you putting them on an easy payment plan of $19.95 a month?
A couple things. A number of those folks that you described could qualify for Medicaid. We have a very high success rate there. But for those patients that truly fall between the gap and they don't qualify for any funding, governmental or otherwise, then we have a program where we discount the bill a percentage equal to the average of our managed care discount rate. That gets adjusted as our managed care contracting gets adjusted. Again, this was the chairman of the board and chief executive officer of HCA, Jack Bovender, testified in front of Congress a couple years ago and introduced this plan to address the very problem that you just raised. So if you're that individual, then you're going to receive a percentage discount, and it's something, it's going to be 30% or more. It's going to be a significant discount and reflect the current discounting that's given to our managed care partners.
Mr. Hastings, if that same gentleman walked into St. Luke's, would he get a slightly higher percentage discount than Mr. Hicks was offering?
Our program is distinctly different, and any of you would like to know the details of it, if you go to our website, it's on the website. But we have actually, we collaborated with KU in this particular area in developing a policy that really relates to the percentage, where their percentage of income is related to the overall population. So those 200% below the federal poverty, or above the federal poverty line, they get a certain discount, and then the discount changes based upon their ability to pay. One of the problems that we have with the high discounts, and I'm sure that every administrator on this row would tell you, that when companies started going to higher discounts, that our bad debts started going up phenomenally. And that's Charity Care is up for all the hospitals in Kansas City, either Charity Care or bad debt, because believe it or not, hospitals and doctors are the last people to get paid out of your take-home income. That's just the way it is, and it's been that way forever. So we do have a plan. There's a misunderstanding by certain groups, because I think most of the hospitals in the region have some plan to address that. The fact is, if you don't have the ability to pay, in our case, it's really based on what your income is, but I guarantee you that there are very few hospitals in this region that would charge you higher than you charge managed care. I just don't believe that to be true.
Joyce Prutella at Shawnee Mission Medical Center.
I would agree. I'll go on record as saying that Mr. Hastings, Mr. Hicks, and I have not colluded on this answer for the attorneys in the room. However, I agree. I think you'd be hard put to find a hospital in the Kansas City area where a self-pay patient wouldn't receive at least a 30% discount off of the charges. I think you'd also find many, particularly in the not-for-profit sector, who have charity care policies, that many of those patients who are self-pay would qualify for even additional discounts beyond that, and I believe that's also true with the HCA system in the for-profit sector. So I haven't seen a private pay patient pay full charges in years, and I think you'd be hard-pressed to find anyone in Kansas City who could say that that was true.
Any more questions for our think tank of experts? I'm running over to this side here, to this lady, Zori Rodriguez, American Academy of Family Physicians.
First of all, I want to commend you for sitting on this panel and addressing some really challenging questions. But I also want to challenge you to consider that maybe annual diversity training, which I've been a participant of and also a facilitator for, is probably really not enough for employees, for those who interact with people on a regular basis, and that maybe if you all could think of ways in which to incorporate some of the concepts into teachable moments, into any variety of trainings or interactions, maybe that might be something that may have an impact on the way people feel when they walk into your doors.
Can you think of one thing that you would believe would make a difference, Zori?
Simple things like, what is the artwork in the room when people walk in? Are there people of the same cultural background presented in your area? I noticed that maybe, I don't know, but maybe all of you happen to be white. I'm supposing that maybe there are other people in your facilities who may have an opportunity to have an impact. There are people who may want to share their stories. Staff in services, staff trainings, people who come in for food days, ethnic food days, whatever it is that people have an opportunity to share their stories or to have an impact on how we present to the people we serve. So there's a variety of ways.
Thank you very much. Joyce at Shawnee Mission Medical Center.
I agree with you that diversity isn't something you do once a year. It's a way of doing business. And we're serious about that. Could we do more? Absolutely. And we consistently are challenging ourselves to do more. I can give you an example of something that happened very recently. One of our African American nurses wrote a paper on observing differences in a healthcare setting in skin color. if you look at many textbooks and even past policies, it'll tell you, observe this change in a patient's skin tone or skin color to figure out what's going on with them. Well, that looks different in the African American population. Who's talking about what the skin should look like in given medical conditions in the African American population? So she wrote a paper on this and then did teaching within the nursing departments at the hospital so that she could spread that knowledge in the research that she had participated in. And I think things like that are going on all the time. I think what we should do is expand on them and celebrate them more, to the point, under the concept of celebrate what's right to get more going on that's right.
Anyone else want to take a stab? Rich Hastings.
I would comment, first of all, it's diversity is constant. We have lunch and learns. Everything that you've said, we do. But one thing that we do more than that, and that is that every employee that has a diversity goal as part of their performance evaluation, from the top down. Mine, I have one myself. And our Vice President for Diversity is sitting over there in the green outfit. She's responsible for keeping me in line as I keep the rest of the organization in line for it. And I think we're the first hospital in the city to have a Vice President for Diversity. We've had it for 4 or 5, no, I guess we're now 10 years old now. So we've been doing this for a long time. And having it as one of your goals and having it be part of your performance evaluation, that kind of gives everybody the full understanding that it's very important to us.
Madam Diversity Officer, is he telling it straight? Okay. Go.
3 years ago, we actually have a diversity section in our strategic plan, which means that my name is not by everything that needs to be done. And so in 5 different areas, we have goals and targets to meet, and all of the people who have responsibility for that are held accountable.
Any more questions for our think tank of experts? Okay, one of the prevailing questions that you asked, which really has nothing to do with disparities in healthcare, but I would be remiss not mentioning it, Mr. Hastings. This came from a number of people. Specifically, what does St. Luke's really get out of a KU affiliation?
Well, had I seen that question before I left my office, I might not have come.
Oh, okay.
Actually, it's a very long question, and I'll try to be brief, but it's hard. First of all, we got involved with this because it's part of the overall Kansas City Life Sciences Initiative. For those of you that know that, we are trying, because of the benefit of having Stowers, which is just right across the street, we have the unique capability as a city to come together, or city and region to come together in life sciences. We are already doing a fantastic job in animal health. We now need to move that on to health and for human beings. And so the major benefit to St. Luke's is the community benefit that comes from it as we are further able to develop. The proposal as it sits, despite what you might read in the various papers, is that we will add roughly 100 residents. These residents are in areas currently where there are no residencies in the greater Kansas City area. So we are actually adding individuals to programs that would be different than either at UMKC or at KU Med. And why for St. Luke's? Because St. Luke's has a large, diverse patient population. We have 11 hospitals, so we can see a patient from, it gives the students, it gives them the ability to see both a rural area as well as a community area as well as a tertiary teaching area. So for St. Luke's, the #1 reason we're doing it is for the community. It has the unique capability of costing us more, and again, it's very difficult to, as you've noticed through the paper, it's been very hard to get all sides to agree to this, but I'm still confident the business community is behind it. The business community has stated it's willing to put another $150 to $200 million into supporting medical education in the greater Kansas City area if we can get this done. And Stowers has said that Stowers 2, the second Stowers, would be put in Kansas City. I don't know which side of the state line. That's not been part of the discussion. It could be, it certainly, from our viewpoint, can be in Kansas. This is, as a matter of fact, St. Luke's is a Kansas corporation. But in any event, that's why we're in it. I could spend hours discussing it because it's taken billions of hours. Well, maybe not a billion. But it's taken lots and lots of hours to get to where we are today.
And Dr. Greiner, does that square with the benefits for KU Medical Center?
Yeah, and again, I'm not sitting here as a hospital representative by any means, more as a university representative and a faculty member. I mean, I think collaboration is always a good thing. I believe in community benefit around collaboration. It's always controversial and it always takes a lot of time. Dr. Michelle Haley just left here, who's a physician that I work with in Kansas City, Kansas a lot on a coalition where we try to get the safety net clinics to work together. And the infighting there is like the same thing as you've seen in the papers for the last 6 months. But after about 10 years, there's actually like joint grants going on and cooperation. And I think that's what we're going to see in the future. You know, the other piece of this that is important for health disparities is that I think research and education and patient care, they really can work together pretty well if everybody's willing to give a little and cooperate. When you do research, you got to also provide service to the community. You got to be giving something back instead of just taking something away. And the same is true for education. When you do education, you need to be serving the community. And it all kind of blends together. And I think this sort of thing can promote that.
The final question goes to James Guillory of the Kansas City University of Medicine and Biosciences.
Thank you. As you consider this additional residency training, are you considering a residency program in preventive medicine and public health?
Since the answer is yes, but we have not made public the various residencies yet, and I really am not at the liberty to provide which ones we're going to do this in. But I can tell you that preventive, not necessarily in public health, but in preventive health, the answer is yes. But I would suggest that that both universities have, as part of their education program, courses in preventive health. So that is happening.
Ladies and gentlemen, our panel has been incredibly generous with their time. They didn't have to appear. Some did prefer not to. But they came and decided to be part of this, and we very much appreciate our think tank of experts doing that. And thank you for caring enough to be part of this conference. We're going to get some concluding remarks in just a moment, but I'm Nick Haynes. I'm appearing here free of charge, and I think you'll agree I've been worth every penny of it. Thank you.